Western Connecticut Health Network has been successful in combining teamwork and information technology to improve patient care.
This success has resulted in national recognition for Western Connecticut Medical Group's primary care practices.
What does this transition mean for patients? Stay tuned to this week's Health Talk.
We're up next.
Professionals would know.
Hello, I'm Dr. Andrea Peterson.
And I'm Dr. Eric Mazur. Today we're going to talk about patient-centered medical home, patient-centered medical care that leads to higher quality and lower costs. Joining us are Dr. Robert Carr. He is the Chief Medical Executive of the Western Connecticut Medical Group, and Rowena Bergmans. She is the Vice President for Integration. And give me your titles because I am messing them up. What's your official title?
Just like Vice President for Clinical Transformation.
Clinical Transformation, and you're?
Vice President of Clinical Integration and Population Health.
So we're with two Vice Presidents here. Welcome.
Welcome to you both
to the show.
Be here.
You go ahead, Viv. You start.
Rowena, maybe you can start our patients off. Just what is a patient-centered medical home?
We hear a lot about it, but I don't think most people have any idea what we're talking about.
Well, it's really focused around team-based care, and what I'd like to do is turn it over to Dr. Bob Carr as the expert and one of the leading folks who brought patient-centered medical home to the state of Connecticut.
So thank you. Becoming a patient-centered medical home is really about transforming your practice and with a focus on the things that are most important to patients. Having good access to care, having good information, being able to have their care managed, being comprehensive so that they can present to one office and be able to get the large majority of their needs met at that office or coordinated to wherever the care is needed. It also has a big emphasis on technology, having the right information at the point of care, being able to track tests and studies and referrals across the network so that it prevents duplication of care and makes sure that the tests that people are having done get returned to the primary care doctor. And it's also, as Rowena mentioned, working as a team, having everybody working to the top of their skill set so that doctors are doing the work that only doctors can do, and nurses are doing the work that only nurses can do, so that a nurse wouldn't be doing something that could be done by a medical assistant or a front desk person. So it really involves everybody on the team and everybody in the office in caring for the patients.
Now, I know this is a relatively new concept, and in fact, we'll get into the structural things that need to be in place. But I think the average person at home might say, Rowena, this is just what my doctor's office always should have been. Well, how is this really different than what my primary care physician, who I've been going to for 20 years, has been doing?
Well, I think there are some similarities, but the differences around team-based care include other ancillary providers when you think above and beyond your physician, right? So in patient-centered medical homes, you may have the addition of care managers, where historically you wouldn't have had that in an old-fashioned physician
And what does that
office.
mean? Because I think unless you've been in the thick of it, people don't know what a care manager is.
So for most of our practices, we have embedded nurses. They're senior level nurses that can really help the patients navigate their way through the healthcare system, which can be complicated at times, especially
the complicated patient who may need rehab or part-time nursing home, or needs a variety of appointments. Though it can be very hard. I've just faced this with my own mother-in-law. It can be very hard to do unless you know the system.
Exactly, and a good example is when someone's coming out of the hospital and they've been admitted to the hospital and they've had changes that have occurred in the hospital. They may be on different medications, they may have a different functional status than when they went into the hospital, and then they're being discharged back into the community, and oftentimes there's a lot of things that they need, and the care coordinators help with that. They help them make sure they're on the right medicines, that they have transportation, that they have the knowledge to be able to do self-care and be able to manage their illnesses so that they don't have to end up back in the hospital.
And there are other additional services beyond nursing services, right? We hear about addressing sort of the underlying psychosocial issues. You may have embedded behavioral health consultants, so social workers also to address a subset of the population's needs, as well as pharmacists, right? So again, it's really focusing the right resources on the right patient population versus a one-size-fits-all.
I think what patients may not realize, but I think Andrea and I would certainly realize, that if you have a nurse practitioner who does only diabetes management, that nurse practitioner can become far superior at much of that to the average internal medicine doc, who's 1 out of 10 patients may have diabetes, or 1 out of 20, or 2 out of 10.
Well, a lot of it is targeting the different jobs that are needed for a patient, because there have been some studies that shows that if a physician alone were to try to do all of the things that need to be done for patients, including taking care of all their acute needs, their chronic conditions, their preventive medicine care, their patient education, their care navigation, there just really aren't enough hours in the day to be able to do that. And
Yeah, I've
so,
seen estimates of 45 minutes to an hour and a half per visit if the
Right.
physician did
And
all
so
that.
if
And that's just not practical in this day and age.
So for a normal-sized practice, that would take about 20 hours a day to be able to do that for an average-sized primary care practice.
And
So by dividing it up into team-based care, so let's let this nurse who's very good at patient education do the patient education. Let's let this medical assistant who's very good at navigating through the appointment system take care of that. And everybody has a role. The patient feels very taken care of. It's almost like building a blanket around them of
This is what you
of
mean by
care.
team-based care, is that you have a team of professionals with different expertise, all of whom are
All working
focused
together.
on that patient, the patient-centeredness of
And
it.
that the patient feels very comfortable that their physician is managing the team and is in the loop for all of those things that are happening, but is not necessarily personally providing every bit of the care that's being done there.
And it sounds intuitively wonderful and really beneficial. What positive effects do we see from patient-centered medical homes?
Well, I mean, there's lots of positive effects. We see a much higher rate of closing gaps in care and providing preventative services, lower readmissions rates, and Bob could probably speak to a few others. But I really do think if you're looking at the patient holistically and not just as a physical part or piece, you're much able to address their needs, and then the outcomes will follow that.
And we really look at patient satisfaction, how happy are patients with the care that
How
they...
happy are patients with this?
Patients like it. Patients like to be able to call and get an answer to their question. And what we do with our care coordinators is the patients get a direct number to call the care coordinator directly. They don't have to go through the switchboard. Many patients get very frustrated with that menu, dial 1 if this and 2 if that and 3 if that, and then they wait on hold for a while, where with the care coordinator model, they get right through and are able to get a hold of someone that will answer their questions. It also tends to be much more satisfying for the staff that become engaged in it, because everybody has an important role in making sure that the patient's taken care of. So it's, for a medical assistant, for example, to be involved in educating the patient and doing depression screening, is much more rewarding than simply bringing the patient to a room and writing down why they're here, which is kind of the traditional model. You asked a little bit earlier about...
I've heard, this is part of the natural evolution of medical care. Now, I've also heard this discussed really as the industrialization of medicine. People will complain that you're going, not many people may remember Marcus Welby. Marcus Welby did everything. He was a TV character who was a physician. He'd visit you at home, he'd visit you in the hospital, he'd do everything. He held your hand, talked about your family, and did all of the things that you talked about. And he was set up, and at that time it was he, as the ideal doc. And in fairness, there are still many doctors in this community and others who practice that way, or try to. It's really the loss of that, though, into a much more system, a kind of a system of care, rather than my doctor and I, it's just the two of us together against the world.
True, but in the traditional model, really, where everything had to go through the physician, everything got, all the questions kind of filtered to the physician, and then the physician dealt with them and then filtered them back out. If you look statistically, it shows that only about half of the actual care that was needed was actually able to be provided. So if you look and see, of all the guidelines that we have, how many of them are actually being met for the average patient in the traditional model, it's really only a little more than half.
The point that I was going to make is, back when Marcus Welby was there, there were no guidelines. There were a couple of immunizations, and that was all they could do. Medicine was very much less complex.
It was.
So that most of what a physician could do was that interaction, that personal interaction with the patient. Now we have so much that we can do that we really, I think, as physicians, are responsible providing that in a quality and comprehensive manner.
And the funny thing is that, we know with variability you have increased costs and decreased quality. So there are some things that you want to standardize, not the personal relationship, but the guidelines and make sure that they're being adhered to. In addition, a lot of patient-centered medical homes actually do home-based visits for a subset of the population. So in some ways, you're actually getting back to that, right? So for, everybody thinks of Marcus Welby, then they think of HMOs, and you got the gatekeeper, and now we're really going back to a system of care where you have higher quality, lower cost, but with that personal touch.
And if you really drill it down to what are the things that physicians really want to be spending their time doing and need to be spending their time doing in part of an encounter, it's kind of complex medical thinking and problem solving and building the relationships. And the new model actually gives physicians more time to do that, because in the past, you were spending so much time searching through charts and looking through records, and did they have this, do they know this, do they, and trying to accomplish everything in one visit, that it was harder sometimes to do some of those other things, where now, when you have a whole team providing these services, the physician can really focus more on building the relationship and on the kind of complex medical problems that really need a physician to be part of.
We've talked a lot about the patient seeing different members of the team. Behind the scenes, does the team meet as a team to help coordinate the care of the patient?
Yes. In most models, the team meets initially in the morning to kind of look at the day and see what's coming, who's coming in, what they might need. We call that a huddle, just to kind of get together at the beginning of the day. And then there are, in the middle of the day, kind of a regroup to look and see how things are going. Are we behind on schedule? Who's coming in? And then there are more formal meetings, too, where the whole office gets together, the various teams, to look at what are some things common across the whole office that might want to be looked at or taken care of.
That's so important to patients and families, too, right? To feel that their providers, their physicians, and everybody else who is involved in their care are actually talking to each other and coordinating the care.
And the patient is at the center of this, right? So the patient is part of that care plan. They help develop it as well. This isn't done to them, so to speak. They're part of the process. So it's not as if it's just sort of an outsider and somebody's going to figure out how to fix you and then inform the patient.
That's
and I know one of several of the tenets of a medical home are that you collect data on what you do and you make that data available to patients. So now that we have guidelines and expectations and screening expectations, which you measure, I think people may not realize for a medical home, they can go out and look at those data and decide how they're comparing to other medical homes and other providers. So finally, patients have the opportunity to kick the tires and take you for a test drive.
They do, and it's also important for them to be able to see their own data. I mean, the data that's most important to you is what metrics are you meeting and not meeting as a patient.
We're running out of time, but I do want to say something about certification because it doesn't happen magically. Can you say something? How do you become certified?
There are a number of different organizations that provide a recognition pathway. The most commonly used, or the largest, is NCQA, the National Committee for Quality Assurance. And they have a set of criteria. It's about 30 different steps and 30 different measures that you follow, everything from access to population health.
So if somebody's interested, can they go to just search NCQA?
NCQA, and patient-centered
medical home.
Correct. And you do a survey, and they, to provide evidence that you're meeting all of those different criteria. And there's different levels of recognition depending on how many of the criteria that you meet. All of our practices in the medical group are level 3, which is the highest level.
That's wonderful. Great. Thank you both so much for all this
future
really
of medicine. This is the
information.
The new approach to healthcare, and I think, as I said, patients will get better care for it. So I want to thank both our guests for joining us, and we'll see you soon
on HealthTalk. Take care.
Thank you.
Bye-bye.